On the topic of EGFR mutations, let's touch on MARIPOSA study, where we're looking at Amivantamab and lazertinib in first line for metastatic non-small cell lung cancer. This combination was also approved just before ESMO on August 19, 2024. Stephen, can you touch on the study design and its recent updates on the resistant patterns that we're seeing?
Sure. So MARIPOSA, a frontline study for patients with common sensitizing EGFR mutations. So your exon 19 deletions, your L858R point mutations, and here randomized to 3 arms. One, the experimental arm would be the combination of Amivantamab, the EGFR-MET bispecific antibody, plus lazertinib, which is another third-generation TKI, pretty comparable to osimertinib. The second arm was osimertinib, which would be the standard, and then the third arm of lazertinib. We did see a comparison of lazertinib and osimertinib presented at the World Lung Meeting that showed those curves really do overlap. And so the difference between MARIPOSA and osimertinib is not the lazertinib part. Really, we would think of that pretty similar to osimertinib. But adding amivantamab significantly improved progression-free survival, leading to its FDA approval, as you mentioned, August 2024. In this update at ESMO, what we looked at, which I thought was very interesting, was the patterns of resistance. Now that we have multiple regimens available in the frontline setting, MARIPOSA, which is amivantamab and lazertinib, FLAURA2, which is osimertinib plus chemotherapy, and FLAURA, which is osimertinib alone, we're starting to wonder which one should we use? What's the optimal sequence for a given patient? And understanding the resistance and how that impacts later therapy is important, because we're not making just a decision on our treatment today. We want to see how it impacts everything going forward. And so we really want to understand resistance. And one might expect that if we're giving amivantamab this whole time, we're really shutting down EGFR and MET mediated resistance, which is a large portion of osimertinib related resistance. And, indeed, Professor Benjamin Best, when he presented these, showed exactly that. We saw the rate of MET amplification went from 14% down to 4%. We saw the EGFR secondary resistance mutations from 8% to less than 1%. And so it's doing what we expected it to do. It's nice to see. One wonders if these cases that broke through are these cases where we had dose reductions, dose holds, or discontinuation of amivantamab. I think that would be pretty interesting. What we also saw in this that I thought was really important going forward was that resistance after MARIPOSA seemed to be less complex. What I mean by that is, when we're treating someone with osimertinib, at the time of progression, when we check, we may see MET amplification, we may see a second EGFR mutation, but very often a second EGFR mutation will occur in the context of many other things. And if we have a population of 100 cells and there are 20 different mechanisms of resistance, it's kind of like spinning plates. It's hard to focus on one because you lose control over here. And so we need something that works for everything. Here with MARIPOSA, it seemed like there were less resistance mechanisms in any given patient. And so suggesting that maybe there's less polyclonal resistance, that maybe resistance is a little simpler, and one might extrapolate from that it might be easier to treat. Of course, that needs to be proven, but I think pieces are starting to align and we're starting to get a little bit more sophisticated.
Thanks for summarizing that. And it's exactly right that how we saw these results, it was sort of expected, but it was nice to see that work out in practice here in this trial. Now, as you stated, FLAURA, FLAURA2, and MARIPOSA. Now, how are you deciding when you are seeing your next patient? Does ctDNA positivity plays or affects your decision here, whether OC versus chemo, along with AMI-LAZ?
I think a lot of the subset data that we've seen from all of these studies has been more prognostic than predictive. And I haven't seen a compelling marker that says this person is specifically going to benefit. But to me, what is still missing is overall survival. Because I think the question is not, should I give chemotherapy and osimertinib or osimertinib alone? It's, should I give chemotherapy and osimertinib versus osimertinib followed by chemotherapy? Really, that sequence, I think, is important. Because if the survival is exactly the same, all I've done with these combinations is increase the time on infusions, increase toxicity. Nobody wants that. And so I really think that the survival is the big piece that's missing.
And while we're talking about MARIPOSA, I think it's also important to at least reiterate that there was increased risk of blood clots that we have to keep in mind. With amivantamab, it's also important now to consider prophylactic steroids till we wait for sub-Q infusion availability based off SKIPPR data that was presented at World Lung by Gilberto Lopez.